This is a case of a 20-year-old male gentleman who was hammering and unfortunately had a metal foreign body lodged into his vitreous. We start with the anterior segment repair and make sure that the eye is tight. Fortunately, it had gone through pars plana and his lens did not have too bad of a cataract, so I elected to not perform a lensectomy at the primary procedure. Initially, I performed a vitrectomy, and you can see that the metal foreign body is about 2.5 disc diameters, if not 3 disc diameters. And I've stained with triamcinolone here to ascertain where the vitreous exactly is. You can see that he doesn't have a PVD, which is to be expected. And I think initially I try and see if I can induce a PVD. However, with this metal on top of it and the difficulties within the PVD induction, I elect to opt to remove the intraocular foreign body first. The issue with that is obviously I have to then enlarge my sclerostomy and I'll probably have a less stable eye. However, I grasp this metal foreign body and proceed to try and pull it through my sclerostomy. Initially, I would like to have used a bimanual approach with a chandelier, just as it provides a bit more control. However, in this circumstance, that was not available to me. So I'm holding the metal piece in one hand and I then enlarge and make a sclerostomy. Unfortunately, it drops and I re-grasp it again, but this time, unfortunately, it gets stuck in the wound, and you can see that it's just lodged there on the top left of the screen. So I go back in and you can see that it's quite anterior at this stage. So I use the light pipe and I manage to get a good grasp on it eventually. And I try and use the light pipe to try and tilt it so that it's more aligned with the sclerostomy wound that I've created. But even despite getting it as close to alignment as possible, I've got a good grasp with the 25 gauge forceps. However, it still gets stuck in the wound. So when it falls back this time, I try and grasp along the IOFB, and you can see that this time it comes out quite nicely from the top left of the screen. The next challenge then is to try and induce a PVD, and I have to go very, very close to the disc. I try several times to go nasal and then temporal to the macula. However, it's rather challenging, and you can see that eventually, through sheer persistence and using the triamcinolone stain, which is very helpful here, I managed to eventually peel the vitreous off the disc. And you can see that it's a very subtle shadow reflex that you can see in the nasal aspect of the video, which will become apparent soon, and that releases the vitreous, allowing me to complete my vitrectomy. So the rest of the vitrectomy after that is pretty routine. You can see that there are some trauma-related stigmata from the intraocular foreign body, and I've sped this part up because it's just a routine vitrectomy. Obviously, I'm being mindful to avoid causing any further damage to the lens. And you can see that there's a significant amount of bleeding inferiorly, and there's a large break, as well as areas where the blood vessels have been damaged and are sclerosed. However, generally his retina looks pretty good and he had good vision, and you can see on the search that the base is pretty well shaven to as close as I would like to take it in a phakic patient. I'm pretty satisfied with how much of a vitrectomy I managed to complete. And you can see that there's a small linear break here temporally. That's possibly iatrogenic, but also very difficult to say because obviously the induction, even though I was trying to use as gentle as possible, it's possible that it caused traction. It was parallel to the site of the entry, so it's understandable if it was caused by traction. And so I then proceed to laser. I try and do laser to all the areas of the break, and I'm still under fluid here, but he has a very good laser uptake. Eventually I go to air, and you can see that I'm able to continue and complete a 360-degree laser. I provide an extra barrier posterior of the inferior border just to kind of shore up any potential future PVR if he develops it, any contractions, and I'm just thinking down the line if he does have the vitreous base contracting and pull a small break, I've got a good barrier of laser. I also cryo the edges of the break, and you can see that he gets good uptake. Once I'm satisfied that I've got good laser, I increase the pressure and make sure I'm drained as much of the subretinal fluid as possible, as well as any pre-retinal fluid so that I can get a good oil fill. He's got some tracking down inferiorly to the nasal disc area, but I'm not too worried about that, especially somebody his age. He'll have a good RPE pump, and I very carefully make sure that he has a good 360 laser, the brakes are adequately treated, and I fill it with silicone oil 1300, and he does well so far.